to the
This
demo.
is really good. Welcome back. Now you know how to detect mitral regurgitation, how to determine how severe it is, and you know some of the pitfalls. Next on our list is to find out how mitral regurgitation relates to left ventricular function and what the cause of MR is in the first place. Patients with mitral regurgitation have volume overload, which means that the regurgitant volume which is pumped back into the left atrium has to be pumped a second time. Therefore, one can expect hyperdynamic left ventricular function. But what about patients who have poor left ventricular function and severe mitral regurgitation? There we have a dilemma, the so-called chicken and egg dilemma. What came first, regurgitation or left ventricular dysfunction? To differentiate the two, we have to introduce the term of functional mitral regurgitation. Take a look at the following case. Left ventricular function definitely is not normal. The left ventricle is dilated, and we have severe mitral regurgitation. Now, of course, this patient could have mitral regurgitation, and therefore left ventricular function starts to deteriorate. But vice versa, there's a second possibility, namely that the dilatation of left ventricle in essence causes mitral regurgitation. And that is what we call functional MR. The structure of the mitral valve is completely normal, but because we have annular dilatation, the valve is incompetent and we get regurgitation. But there is a second mechanism of functional mitral regurgitation as well. Some patients have a distorted ventricle, for example, after myocardial infarction. And in these patients, the papillary muscle is kind of dislocated more towards the apex, and thereby we have chordal structures which are pulling onto the mitral valve and thereby causing incompetence. We call that restrictive mitral regurgitation. Frequently, we have a combination of both restriction and annular dilatation. But whatever the mechanism is, in both cases, the valve is structurally completely normal. This patient has myocardial infarction. We see there is akinesia here. The ventricle is distorted. Therefore, the posterior leaflet is kind of restricted in its motion. In addition, the annulus is dilated, and as a consequence, we have mitral regurgitation, which is rather severe. And you see in this patient, left ventricular function is poor, not only because the patient has a scar, but also because there is hypokinesia of the remaining part of the ventricle. So mitral regurgitation in this case is definitely not a good thing to have. Functional mitral regurgitation is the first big category. The second is structural MR. Here are some examples. This is a patient who has what we call a flail leaflet. A part of the leaflet is actually ruptured. This is a TE study which nicely shows the part of the leaflet which is ruptured and which now protrudes into the left atrium. And this causes, obviously, mitral regurgitation with a jet which is pointed here towards the interatrial septum. Here's another example, again a TE study to help you look at the morphology better. A mitral valve which has a mitral valve prolapse. You see that part of the leaflet is protruding again into the left atrium. Maybe there's even a very small partial flail leaflet here. You see that the leaflet is thickened, and it's structurally definitely not normal. And this is what we call structural MR. I'll show you more examples of structural MRs later, but at this point, here is rule number 4. Left ventricular dysfunction can be cause or consequence of mitral regurgitation. And we have another rule, number 5. MR can be both functional and structural. This brings me back to the patient I showed you in the first part on mitral regurgitation. Do you still remember? This is his 4-chamber view, and if you look at the mitral valve, at the morphology, you will realize that it's definitely not a normal mitral valve. It's thickened, and in the apical long axis view, I'm sure you will appreciate that part of the posterior leaflet is protruding behind the anterior leaflet, and that again we have the suspicion that this is a flail leaflet. If you look at the regurgitant jet, it's directed towards the interatrial septum. It's very eccentric. Do you recognize the pattern? Well, this brings us to the next rule. Eccentric jets indicate structural MR, and very frequently the cause is a flail leaflet. Now, the variety of different structural defects is very, very large. I wanted to show you a few examples. What about mitral regurgitation here? Well, the mitral valve definitely is not normal here. You've got thickening, calcifications even in the basal part of the anterior leaflet. The reason is that this patient has a perforation of the anterior leaflet caused by endocarditis. Next example. Again, a thickened mitral valve. The entire valve is thickened. We have a prolapse here, and if you look very closely, you will see that a part of this leaflet here, again, is flail. Very similar to the cases we've seen so far, an eccentric jet, severe MR, pointing towards the interatrial septum. Remember our rule? What is the problem here? It's a flail leaflet. Next example. If you still remember the previous chapter, you will make the diagnosis. We have doming of the anterior leaflet, which means that the patient probably had rheumatic heart disease. And rheumatic heart disease can also cause incompetence of the mitral valve. This is the problem here. What about this patient? Again, a structural defect of the mitral valve because the mitral valve is thickened, and not only is the anterior leaflet prolapsing, but also the posterior leaflet. This is an example of a classic mitral valve prolapse, or Barlow disease, or myxomatous mitral valve, as we also call it, with severe mid to late systolic mitral regurgitation. See the jet here? One last example. Is the morphology of the mitral valve normal? Well, there's a little bit of mitral annular calcification maybe, but this is pretty much trivial. The mitral valve itself is structurally completely normal, but still we have mitral regurgitation. Why? Because we have a dilated left ventricle with poor left ventricle function. So mitral regurgitation here is definitely secondary to remodeling of the left ventricle. We have functional MR. But what about our patient? Well, first we performed rate control. We gave him diuretics to recompensate him. In retrospect, I'm pretty sure that the flu he reported was in essence the moment when the flail leaflet ruptured. Now he's waiting for cardiovascular surgery to repair his mitral valve. Now that we answered all these questions, let's put this into a clinical context and image a patient together. First, we want to focus on the morphology of the mitral valve.
Yes, and here we have today a patient of ours, and I will image the mitral valve first using the parasternal approach, long axis, and we can actually immediately see that the mitral valve is a problem, especially the posterior leaflet.
I mean, this is one view, and you immediately get the diagnosis. It's very simple. The valve is prolapsing, a part of the valve. Which leaflet?
It's the posterior leaflet, which goes above the annulus into the left atrium. And actually, we need only one view to make the diagnosis.
So sometimes it's quite simple. The valve is also thickened. That fits very nicely to a mitral valve prolapse. But there's much more information in the echo.
Yes, when we use other views, actually we can confirm our suspicion and diagnosis. So when we go to apical four-chamber view, we see again the
Wait, I think you had this is a beautiful view now. Right now, you see, this is not only a mitral valve prolapse, but something else is going on here.
Yes, actually, we can really detect that there is a rupture of the chordae. So the prolapse becomes actually a flail leaflet in the context of a degenerative disease.
So I'm moving the trackball back and forth, and you can see that this is a small little rupture of the chordae right here. So the diagnosis is clear. We have mitral valve prolapse with a flail posterior leaflet, which obviously, as you will see later, will cause mitral regurgitation. So the key message here is the mitral valve can have a problem because there is a structural defect. Are you ready for another patient? Well, Anna, this is definitely not a normal mitral valve.
Yes, it is actually. The tissue is really redundant and the leaflets are thickened. And if I tilt a bit the transducer, the problem appears.
See, we have a part of the leaflet which is flail, and we see that part of the posterior leaflet actually goes below the anterior leaflet. It's the so-called parallel sign, as I always call it. So the diagnosis is quite clear. What we have here is a typical myxomatous mitral valve, a structural problem of the mitral valve with a partial flayed leaflet. So again, a disease that is relatively common, even though you might not always see it in such an, I would say, extensive form as you see it in this patient here. I hope this demo was helpful in showing you how to assess patients with mitral regurgitation. And this brings me to the next very important rule. The most important factor for quantification is image quality. And to demonstrate that, take a look at these two images. The same patient. On the left, with poor image quality, maybe mild mitral regurgitation. On the right, good image quality, severe mitral regurgitation. What is the difference? Just a little motion, a little bit more pressure applied to the transducer, and this is what you get. The same thing can be seen here in the apical long axis view. Maybe mild regurgitation, and here is moderate regurgitation. So the key message here is practice. This will be more helpful than studying and learning different complex techniques of quantifying mitral regurgitation. In our patient, we already assumed that there will be some degree of mitral regurgitation. Now we need to find out how much it is, and for that we will need color.
Exactly. Here I'm going to assess the severity of this valvular disease, and when we put color Doppler, we can immediately see the regurgitant jet.
So the jet that Anna is talking about is this here. It's kind of difficult to really appreciate the jet. Is this the ideal view to look at regurgitation?
Well, actually, in some patients it is, because when the jet is especially eccentric, we can have our ultrasound beam really parallel to the jet. So
sometimes it is.
Be.
Yeah. But in all patients, we usually look at regurgitation from several positions, and we will now go to the apical view and see if we see more of the jet, for example, in a four-chamber view.
Yes, Thomas, I'll show you. The jet is, of course, confirmed here, eccentric. It goes towards the interatrial septum.
Yeah, perfect. You see, the direction of the jet is right here towards the interatrial septum. And the reason is very simple, because we have a regurgitant orifice which is pointing to the interatrial septum because there's a flayed leaflet. But how severe is regurgitation?
Well, with color Doppler, it's not really easy to assess when we have eccentric jets. So remember, always scan the valve to see the maximum jet, and then focus on the proximal part of the jet, which stays in the left ventricle, because this is a good indicator of the severity.
Remember our rule? This is what we should be looking for, always the proximal portions of the jet. In other words, the vena contracta here and the flow convergence zone. And in essence, we usually tend to underestimate the severity of the jet, but you know that already. As you saw in the demo, we move away from the standard view for a very good reason. Simply because we have to image the mitral regurgitation jet according to where it is and not where the standard views are. And this is exactly rule number 8. Optimize the image to the jet and not to the correct view. Now, this is neither a two-chamber view nor a short-axis view. It's somewhere in between. And we're imaging it because that's where the jet is. You see that it's very eccentric and it's severe. We would probably not detect the full extent of the jet if we used only the standard views. Rule number 9, use multiple views. This is understandable if you look at this 3D echo of a reconstruction of an MR jet. You see, the MR jet is not symmetric, but it's pretty bizarrely shaped, and if you want to get a good appreciation of the true size, you have to look at it from different angles. And this can be done by using multiple views. And finally, the 10th, and for me the most important rule, use an integrative approach. What does that mean? Put all the information you have together, not only the echo information, but also the clinical information. Because in the end, you have to make a decision what to do with the patient, and all this information will be valuable and important. So we now know that the patient has mitral valve prolapse. We know that mitral regurgitation is severe. The only thing we still need to find out is how good his left ventricle function is.
Yes, and from the four-chamber view, we can actually see dimensions and function of the left ventricle. So the function still seems preserved. but maybe the diameter is...
Yes. The ventricle, I think, does look a little bit dilated from a visual aspect, but we can measure that. We can freeze the image and then go to a frame where we have the largest diameter, and then we simply just measure the diameter, and here we are with a diameter of 60, 61 millimeters, and I guess you will all agree this is a mildly dilated left ventricle. But we still need to look at the ventricle from all portions because there could be regional wall motion abnormalities, right?
So for this reason, use all the views, so 2-chamber and 3-chamber then, to assess again left ventricular function, and still I think we can confirm that the ventricle is functioning well.
Yeah. And what does this mean for the patient? Since he's asymptomatic, it means we do not need to operate on the patient at this point. Of course, we'll follow him up, but I think he's very happy if he does not have to be operated at this time, right? Okay. In our masterclass, we're going to extend on what we showed here. We're going to show you how to use other quantitative parameters such as PISA and measurement of vena contracta, and we'll also look at many, many more examples which will in essence make you a true master.